Today is a posterior contralateral transfalcine approach for left cingulate and precuneal cavernoma. Neurosurgeon Michael Talabayev, assistant Kevin Venegas and Hanna Mashkova. From the Pediatric Neurosurgical Department, Republican Research and Clinical Center of Neurology and Neurosurgery, Minsk, Belarus. We present a male 14 years old. In 2020, anaplastic astrocytoma from right frontal lobe was removed. Clinical outcome, left hemiparesis, MRC 3. He had complex oncological treatment, 8 blocks of chemotherapy and 32 courses of radiotherapy. In 2023, the child had a generalized tonic-clonic seizures. MRI has shown a cavernoma of the left cingulate gyrus and precuneus with hemorrhage. EEG study, moderate non-specific violation of the cortical rhythm was shown. This is a T1 isotope MRI of the patient. We see the cavernoma and how we approach. We are doing the contralateral approach in order to save more the cortical part of the left hemisphere, as I believe. Lateral position of the patient. Also, we remove CSF by lumbar puncture around 40 milliliters in order to relax more the brain. And neuronavigation brain light was used. The patient is in lateral position. We see where is the sagittal sinus. Proceeding, we are opening the dura mater. We see how very gently is opening the dura in directions. It is in the upper part, the sagittal sinus. After that, we very gently try to open the interhemispheric to do the interhemispheric approach with a pad, the rubber. We stitch the dura mater for more easily approach. Now we use the cotton pad on the rubber sliding through the interhemispheric space. We see now where is the falx. We're coagulating the falx with a sharp blade. We're opening the falx. To make it more wide, we use an instrument in order just to leave the falx, coagulate, and then cut. Now we see where is the precuneus. We check in the neuronavigation system. We see that we are in the right place. Now, by opening, we see where is the cavernoma and coagulating. I want to notice that cavernoma, we are coagulating from the peripherally in order to shrink the cavernoma, and it's becoming more small. After that, trying to do a dynamic movements in order to completely to see all of the vessels that are in this cavernoma. We're using the next bipolar with different angle because it was not approachable by the straight bipolar. Now sucking and coagulating. We see there is some parts of already brain with hemosiderins that also we are removing. This is the cavernoma again, mobilizing. We are trying to do a dynamic mobilization of the cavernoma in order to get less injury to the brain, adhesions. Now we are working in the small angles, removing hemosiderins from that is left of that cavernoma. So we believe that his hemosiderins is provoking also the seizures. Now we see we're checking all the angles, that is total resection. Now we're using hemostatics, and as we see is small approach around 3 centimeters that we open the dura mater. After surgery, we see the T1 isotope MRI control. We see that total cavernoma removal. Also any signs of hemorrhage, and we see that good approach, and we work with the good angles. Thank you very much for your attention.